Greetings. My name is Shane Mathew, and I'd like to detail my outcomes collection experience for Evidence-Based Practice 3. This project took place in a metropolitan area in Tennessee, and I took outcome measures on a total of 25 patients across 5 different body regions, including shoulder, neck, low back, knee, and hip. So for this project, we were seeing patients in an internal hospital system. This was an outpatient clinic. Patients were seen approximately 1 to 2 times a week, and all patients were seen internally through referrals in the hospital system from their orthopedic and sports medicine staff. The patients totaled to 25. Their ages varied significantly between 12 to 73 years, which I'll explain a little bit how that factored into my outcomes. There were a total of 11 males and 14 females that were seen during this experience, and the average comorbidity burden of the patients that were seen was 2. For the interventions that were provided under the project, each patient was seen by me, and I made it a concerted effort to make sure that the scheduling staff knew that those patients were to be seen exclusively by me during the outcomes collections. The outcomes were collected for 3 time point intervals, once at the initial evaluation, once again about 2 weeks later at week 3, and then again at week 5. And then that's when their plan of care per facility guidelines was over, where they required discharge, or their plan of care needed to be revised for additional visits. Each patient was seen for approximately 30 minutes in length, and that is also for the facility guidelines. We could only see patients for 30 minutes, including evaluations and follow-up appointments. And each patient was seen with a warm-up for approximately 5 minutes, depending on their body region of complaint. So if that was for the upper body, like the neck or the shoulder, they would be on the UBE for about 5 minutes. Or if it was low back, knee, or hip, they'd be on the recumbent bike or elliptical, for example. Followed that, we have interventions that were stratified based on the ICF domain of impairment that was identified at the original evaluation. So if they were noted to have decrease or deficits in strength, we prioritized strength maneuvers and strength activities. If range of motion was an issue, mobility was the priority, so on and so forth. Manual therapy was used, but sparingly for cases of increased pain and irritability or significant capsular restrictions to soft tissue. Looking at our outcomes here, I detailed my outcomes in a line graph like this. I understand that this might be a little bit hard to read, but allow me to explain. So the first 2 lines at the top here are reflective of the LEFS, where if you were to see a patient that improved over the course of their care, their score would go up. Below, we have the quick dash, the NDI, and the ODI, which, as you might know, they will decrease in score if the patient improves in value. So I try to condense this as best that I could within this chart here to give you a little bit more of the numerical basis for my findings. All patients seen either met or exceeded their MCID. So if we look at figure 2, my personal average is documented in blue. The class average was documented in orange. And finally, the MCID for that outcome measure is documented in gray. So as you can see, my outcomes improved across the board. Now, if you look at LEFS for both the hip and the knee, we have significant changes. And allow me to explain that as well. So we see a huge uptick in my scores. What I hypothesize is the reason for that is the patients that we're seeing in these diagnostic categories were typically younger, so between 12 to 30 years of age, and they were seen mostly post-operatively. Now, as we know, if we see a patient post-operatively at time point 1, you're going to see a very big decrease in their outcome measure because they're not able to do much right out of surgery. Going into time period 2 and 3 at weeks 3 and 5, you can see a significant increase in their scoring for those areas, especially if they're able to do more over the course of a couple of days or weeks and post-operatively, and if they're younger too, which I believe can explain why these scores are a little bit higher than to be expected. Most of the patients that were seen for the knee category were either ACL repairs or meniscus repairs, and hip was either a debridement surgery or tendonitis procedure. So I'm happy to report that these averages remained consistent, and they, especially for the LEFS for the hip and the knee, they may not have been sensitive enough to capture functional improvement with such a huge increase. So for situations like this, I would definitely recommend more of a performance measure to kind of help gauge their functional status to help guide clinical decision making. This was a fantastic project to participate in. Thank you to everyone that was able to contribute, and the department as well. Thank you for listening, and I hope you have a great day.